Currently, isotonic crystalloid solution is widely utilized for fluid therapy in the pre-hospital environment. The aim of fluid therapy, as determined by Ravel et al. In 2002, is to restore organ perfusion by increasing circulating volume, thus increasing cardiac output. According to the Queensland Ambulance Service's 2019 drug therapy protocols, fluid therapy is indicated in patients who present with inadequate tissue perfusion, shock, hypovolemia, and significant burns. Fluid therapy is commonly used in the pre-hospital environment, however, is a widely debated topic and raises many concerns for the safety of patients who receive fluid therapy. Although it serves many benefits when administered correctly, Ravel et al. In 2002 pointed out that the incorrect use of fluid therapy may cause adverse outcomes for the patient and in some cases death. This video will bring to your attention the risks associated with IV fluid therapy in the pre-hospital environment, including air embolisms, fluid overload, organ damage, burns injuries, traumatic brain injuries, and coagulation effects. We'll prove to you that it is reasonable to conclude that fluid therapy in the pre-hospital environment should not be utilized to ensure safer clinical practice is delivered to patients. There are numerous complications which may occur as a result of fluid therapy, with perhaps the most obvious being fluid overload. This particular complication has been related to increased mortality, according to Grandado et al. In 2016. When a patient is administered fluid too quickly, or when too much fluid is administered, it will result in water intoxication. This is a severe condition that Hilton et al. In 2008 stated can cause an increase in plasma osmolarity and can lead to severe headaches, coma, and even death. Grandado in 2016 also stated that when a patient receives an overload of fluid, an abundant array of complications may occur, including congestive heart failure, resulting in pulmonary edema, delayed wound healing, tissue breakdown, and impaired bowel functions. As explained by Sherman et al. In 2016, congestive heart failure as a result of fluid overload transpires due to the heart failing to pump the expended circulatory volume effectively. They also indicated that the overdistension of ventricles will potentially cause heart failure and result in pulmonary edema. According to Floss et al. In 2008, these complications may lead to breathing difficulties, symptoms of a cough, further edema in the extremities and around the visceral organs, gastrointestinal ischemia, respiratory distress, and an imbalance of electrolytes within the blood, which may disrupt organ functions. On their paper relating to this, Hilton et al. In 2008 discussed how this edema caused by the fluid overload thereby cancels out the potential benefit, which is the increased oxygen delivery, of administering fluids due to a decrease in the ability for adequate gas exchange to take place. Hilton also states that while steps may be taken to counteract fluid overload, unfortunately by the time this peripheral and or pulmonary edema becomes apparent, the patient has already been harmed by the excessive overload. Dundup in 2017 indicated in their work that two major precautions must also be considered in cases where giving a patient IV fluid therapy may seem feasible. These are the high risks of causing organ damage or when there's already a history of organ damage. These precautions relate specifically to patients who have a history of renal impairment and or congestive heart failure. According to Dundup, once again, renal failure affects roughly 15% of the world's population and limits the kidney's ability to adequately filter blood in order to remove waste and maintain a homeostatic fluid and electrolyte balance. This has potential to lead to tissue edema, electrolyte imbalances, and numerous other potentially life-threatening conditions. The National Clinical Guidelines Centre of the UK in 2013, as well as SAYA in 2014, explain how, on a day-to-day basis, the body is accustomed to having slight changes in sodium and water intake, and as such, compensatory mechanisms like the renin-angiotensin-aldosterone system come into play to compensate for these alterations. However, when a sudden and large volume increase occurs, osmoreceptors may not be able to adjust the blood plasma osmolarity effectively enough to restore that imbalance. To be brief, Pellicori et al. In 2015 defined heart failure to be occurring when a person's ventricles cannot pump all the blood into the aorta or pulmonary artery, thus causing an increase in pressure starting in the ventricles and then going back up into the atria and eventually the surrounding blood vessels. One potential cause can be drawn back to the aforementioned renal failure, thus either resulting in or exacerbating fluid buildup in the heart. Now, given that congestion may not be clinically evident in a pre-hospital environment, and that heart failure has one of the highest hospital admission, morbidity, and mortality rates, it would seem apparent that doing ever possible to keep these numbers down would be quite logical. Pellicori also discussed how uncontrolled hypertension, such as that which may be the direct result of giving IV fluid therapy, is another way to potentially bring about an acute heart failure. Thus, given the inability to understand exactly how giving a patient IV fluids in the pre-hospital setting will interact with their body, and the inability to appropriately monitor every aspect of the body it may affect, the National Clinical Guidelines Centre of the UK in 2013 concluded that IV fluids should be given as a last resort, where ideally the patient should be encouraged to have oral fluids, thus limiting the potential for the adverse effects as previously discussed. Sherman et al. In 2016 identified an air embolism as being another complication which may occur as a result of administering sodium chloride 0.9%. It's a life-threatening occurrence that is caused by air entering the systemic circulation via an IV line. The severity of symptoms resulting from an air embolism vary according to the amount of air instilled and the end location of the bubble. Patients may be asymptomatic or may have complete cardiovascular collapse, causing death, according to Sherman's 2016 paper. In 2017, Natal et al. Expressed that cardiovascular collapse occurs in this instance when rapid entry or large volumes of air enters the systemic venous circulation, putting substantial pressure on the right ventricle, resulting in a dramatic increase in pulmonary artery pressure. This increase will lead to right ventricular overflow obstruction, which will further compromise pulmonary venous return to the left side of the heart. Natal in 2017 also describes how this diminished return will then lead to decreased left ventricular preload with resultant decreased cardiac output. According to the QAS Burns CPG for 2019, the treatment of burns using IV fluid therapy is generally advised for patients with burns affecting greater than 20% of the total body surface area in adults and 10% in children. Guidelines regarding fluid therapy is not presently indicated for fluid therapy for burns that only affect less than 20% in adults and less than 10% in children of the total body surface area, or have a time to hospital of less than 30 minutes. An article done by Greenhill in 2016 states that fluids should not be administered in the event of significant facial, neck, or upper chest burns due to the adverse effects of fluid therapy, which increase the risks of interstitial edema and tissue swelling. Greenhill in 2016 also stated that these adverse effects may increase the chance of the airway becoming compromised. These patients should generally be treated with oral hydration rather than any intravenous fluid management, as it is a safer technique to use when appropriate, as stated by Heberl et al. In 2010. Patients that receive fluid therapy for burns affecting greater than 20% of the total body surface area, depending on their age, may also be exposed to an array of negative adverse outcomes. Gilbert et al. In 2016 explains how patients receive larger amounts of fluid in the first 24 hours than any other trauma patient because of the pathophysiological mechanisms occurring in this injury. Thus, over-resuscitation of fluids is a significant factor increasing the risk of negative adverse effects. Gilbert et al. Also discuss how this over-resuscitation post-burns has been shown to be associated with an increased incidence of pneumonia, bloodstream infection, acute respiratory distress syndrome, multiple organ failure, and death.
A factor affecting mortality includes how administration of intravenous sodium chloride 0.9% in the pre-hospital setting creates delays in transport time and therefore delays the delivery of definitive care in hospital. Several authors have studied whether fluid resuscitation in the pre-hospital setting improves survival or should be delayed until the patient reaches hospital. A study completed by Svensson and Hahn in 2000 states that intravenous cannulation contributes to an average increase of 3 to 12 minutes of additional scene time, which was associated with paramedic interventions. Another study completed by Hunt et al. 2000 released results similar. It also states that for pre-hospital times of less than 30 minutes, the use of on-site intravenous fluid replacement provides no benefit, and that for longer times this intervention is associated with significant increases in the risk of mortality. Hunt also states that although some healthcare professionals argue that intravenous sodium chloride can be given en route to hospital, this may not be possible if the transportation time is faster than the administration of the medication, and thus providing this intervention will increase on-scene time. The most common cause for traumatic brain injury is from a motor vehicle accident, falls from a height, physical assaults, and playing sports. Traumatic brain injury is often associated with hypovolemia, and fluid resuscitation is the generally first-line therapy to restore lost intravascular volume. In the pre-hospital setting, minimising secondary brain injury is paramount when managing traumatic brain injury cases. The risk of secondary brain injury may be caused by hypertension, hypoxia, abnormal carbon dioxide levels, or increased intracranial pressure, and can exacerbate a traumatic brain injury. Currently, a pre-hospital fluid resuscitation is warranted for prevention of secondary injury in managing traumatic brain injuries. Resuscitation using crystalloid fluids is commonly used to restore and maintain adequate cerebral perfusion and oxygenation. However, there are some concerns for fluid resuscitation regarding traumatic brain injury patients. While securing adequate perfusion and oxygenating the brain is an indication for fluid therapy, it may also cause a disturbance of hemostatic clots in blood vessels, thereby causing further intracranial bleeding. One study reveals that a negative balance of excessive fluid of more than 594 millilitres was found to be associated with poor neurological outcomes in severe traumatic brain injury patients. Hemorrhage in trauma patients continues to be among the leading causes of preventable deaths. These patients are highly susceptible to the development of trauma-induced coagulopathy, which only further increases the risk of mortality. Current management of hemorrhage patients in the pre-hospital setting involves the use of 0.9% sodium chloride to provide fluid resuscitation in an attempt to reach a state of hemostasis. Research has shown that this type of management has the potential to induce the lethal triad causing exacerbation of coagulopathy. The lethal triad consists of hypothermia, metabolic acidosis, and hemodilution, all of which, when occurring simultaneously, can have a dire impact on the patient's condition in terms of developing coagulopathy. Administering fluid resuscitation can have severe hypothermic effects on the trauma patient, as normal saline at room temperature is approximately 20 degrees Celsius, which is dramatically lower than that of the desired 37 degrees Celsius average body temperature. Research has shown that even mild hypothermia, 32 to 36 degrees Celsius in trauma patients, has the ability to cause detrimental effects on the coagulation system due to impaired platelet function and inhibition of clotting factors. Acidosis occurs when the body's pH levels fall below 7.35 and is a very rampant complication in hemorrhage patients. This is due to poor perfusion to the tissues, causing a rapid buildup of lactic acid within the tissue, which in turn causes a detrimental drop in the body's pH level. Using 0.9% sodium chloride induces an electrolyte imbalance due to the solution having a substantially different composition to that of the blood plasma it is being used to replace. One electrolyte in particular being chloride, as the saline solution has a greater concentration of chloride than that found in human serum. This has a major influence over the strong ion difference in the human body, as chloride is the main negatively charged electrolyte in the human body's extracellular space. When there is an increase in chloride ions, the strong ion difference decreases, and the body compensates by increasing hydrogen ions. This results in a drop in the body's pH levels, causing an increase in acidity, which may be further worsened when a fluid bolus is given too rapidly, leading to hyperchloremic metabolic acidosis. According to Finfer et al., this may lead to multiple long-term problems, including impaired renal function due to the kidneys not being able to reabsorb bicarbonate due to the high levels of chloride, as well as damage to the lungs, liver, and gastrointestinal system. Finally, using normal saline in fluid resuscitation in hemorrhage results in hemodilution occurring due to it not containing the same clotting factors as the lost blood. While it may be increasing the fluid volume within circulation, it is also simultaneously diluting the remaining clotting factors within the blood, decreasing the body's ability to stop the bleeding, therefore increasing the effects of coagulopathy. In conclusion, it is evident that fluid therapy in the pre-hospital environment puts patients at a high risk of adverse outcomes. We have discussed the risks associated with pre-hospital use of fluids, including time delays, air embolisms, fluid overload, traumatic brain injuries, and coagulation. We believe that it is time to revise the current protocols surrounding fluid therapy and produce safer guidelines and indications for fluid therapy use in order to ensure that patients receive the most safe and effective care possible. How many more people must be impacted by fluid therapy in order to spark a change?